So heart failure is the commonest reason of admissions through ER in patients who are more than 60 years. So it's a very, very big problem. It causes huge toll, economic toll, and life loss for a society, for a nation, and for the world. And people don't know that heart failure mortality at 5 years is more than many cancers. Even cancers like breast cancer, Hodgkin's lymphoma, even leukemia, their 5-year mortality and survival mortality is more than lesser than heart failure patients. So it's roughly around 50% of the patients die at 5 years. And this is a progressive disease with very high mortality. Once the patient develops decompensation and he gets admitted, and the future course becomes even grim. So as a whole, it's a large problem for society, nation, and for the entire world. Yes, India has got its unique challenges, and our patients are younger patients. In world, globally, outside India, the mean age of heart failure patient is something around 72 years, which in India we see at 53 years. So we have younger patients of heart failure, and we have very high hospital mortality. So something which is around roughly 4% in the Western countries, we have seen mortality up to 25 to 30%. So huge in hospital mortality and very high post-discharge mortality in Indian patients, something like 25%, which is roughly around 8 to 10% in Western world. Yes, this is a very important point. When should we shift the patients who are already on ACE inhibitors or ARNI? So the illusion of stability of heart failure, I must tell you, heart failure is never stable. So this is a big illusion. So there's 20% of stable patients in paradigm heart failure trial had a primary event. So these patients were never stable, as 1/5 of the patients were having a primary event. 17% died during the course of the trial, and of patients who experienced a primary event, death preceded heart failure hospitalization 51%. So huge morbidity and mortality in patients apparently who are in stable heart failure. So that is why we have to have our guards on every time, and ARNI should be started as early as possible. Do not wait till deterioration occurs, because every decompensation heart failure hospitalization will take the patient further down in the future trajectory of their clinical course. So very, very clear, HFrEF management, ACC, AHA, Heart Failure Association guidelines are there. It's a class 1 indication that even though patient is stable, we have to switch a class 2 to 3 patients to ARNI as early as possible from ACE inhibitors or ARNIs. Yes, so acute decompensated heart failure, I just told that it is different from de novo heart failure because the mortality prognosis in these patients are not good. So we have to introduce the best possible treatment as early as possible, and that is why we look for the opportunities to start ARNI in these patients before discharge, and that's what was studied in Pioneer Heart Failure trial, where the patients were having acute decompensated heart failure, and all these patients had ejection fraction of less than 40%. And what the Pioneer Heart Failure trial showed, that as compared to enalapril, sacubitril valsartan once started early before discharge, although the patients were not on anatropes or intravenous furosemide, there was a significant reduction in mortality and primary cardiovascular death or heart failure hospitalization, the primary events in the sacubitril valsartan group. So with Pioneer Heart Failure data, if we see a subgroup of patients, especially diabetic patients, especially those patients with a even lesser ejection fraction, they performed even well. So with this, if we contemplate Pioneer Heart Failure data, we have to start ARNI just before discharge of the patient, provided the patient is off inotropes and off intravenous diuretic injections. So once again, if the patient was not having an acute decompensated heart failure, so a patient was not diagnosed earlier, first time he comes and lands up in hospital, because of heart failure. So again we have reports and global report heart failure registry that in this group of patients, if we start ARNI early before discharge, we get a significant reduction in future events, and the the patients of future decomposition becomes very lesser in incidence. So it is very wise to start, and we have got a transition study also, reversal or remodeling study, which indicates that if the patient gets admitted, de novo patients, it's wise to start ARNI as soon as you get the window of starting it. So when we use ARNI, basically to starting dose is 50 mg twice daily, and this is something like if we have a patient on enalapril of 10 mg or a 5 mg, then we can safely start the patient on this dose of ARNI after 36 to 38 hours. But we have to wait when the patient was on ACE inhibitors. But for ARBs, we must start the next day, or the next dose of ARNI can be given instead of ARBs, and the equivalent dose of 50 mg twice daily of ARNI, sacubitril valsartan, is something around 40 mg of telmisartan or 20 mg of olmesartan. So this way you can up titrate. Many of the physicians, they start with 50 mg half tablet twice daily, and then they up titrate. And the up titration should not happen very quickly in 1 or 2 days, at least 2 to 3 weeks time to be there as interval in up titrating the dose of ARNI to a next level. So this is how we up titrate and change from ACE inhibitors or ARBs to ARNI. Yes, very important point. Target dose achievement is very important. What are the challenges? Challenges number one is patients are already on diuretics. Patients are already, some of the patients are on antihypertensive medicines like calcium channel blockers, and they can create some problem in adding ARNI, because ARNI can reduce blood pressure in these patients. So we have to be very careful that patient is eovolemic, not dehydrated. Correct dose on there should not be much antihypertensive like calcium channel blockers, or some nitrates are given. They can also reduce blood pressure a little bit. So hypotension is the biggest reason of non-starting or difficulty in continuing ARNI. So this has to be very clearly seen and treated. And second is some patients feel giddy even if at BP of 95 or 100. They should be counseled well, and the patients do well. And a very minority have got sudden spike in creatinine level. So there also we have to be little watchful. Potassium level, and we have to monitor these in initially at 2 to 3 weeks interval, and then next again after 4 to 6 weeks, and the patients remain stable, then we can continue and increase the duration of monitoring. So ARNI can be well tolerated if we use and start it judiciously. Yes, very important point. Target dose achievement is very important. What are the challenges? Challenges number one is patients are already on diuretics. Patients are already, some of the patients are on antihypertensive medicines like calcium channel blockers, and they can create some problem in adding ARNI, because ARNI can reduce blood pressure in these patients. So we have to be very careful that patient is eovolemic, not dehydrated. Correct dose on there should not be much antihypertensive like calcium channel blockers, or some nitrates are given. They can also reduce blood pressure a little bit. So hypotension is the biggest reason of non-starting or difficulty in continuing ARNI. So this has to be very clearly seen and treated. And second is some patients feel giddy even if at BP of 95 or 100. They should be counseled well, and the patients do well. And a very minority have got sudden spike in creatinine level. So there also we have to be little watchful. Potassium level, and we have to monitor these in initially at 2 to 3 weeks interval, and then next again after 4 to 6 weeks, and the patient remains stable, then we can continue and increase the duration of monitoring. So ARNI can be well tolerated if we use and start it judiciously. So hypertension management with ARNI is very important. We have to see that patient is not salt depleted, volume depleted, and remove the loop diuretics as early as possible if the patient is starting the patient on ARNI, and get rid of other unnecessary drugs. If the patient doesn't require a calcium channel blocker, don't give nitrates if the patient doesn't have chest pain. And if the patient was on ACE inhibitor ARB, then you can make an idea which dose of ARNI would be suitable to these patients, and when the patient was not on ACE inhibitor ARB, start from the lowest possible dose of ARNI. So this is how we manage the hypertension. Yeah, ICD, CRTs, they are a wonderful therapy, but we have to acknowledge this fact that many patients, if we give guideline mediated therapy, ARNI, and then beta blockers, then MRAs, and then SGLT2 inhibitors, many of these patients' ejection fraction improve. And then we have trials, we have many trials which show that the ejection fraction has significantly increased when ARNI was given. The reverse cardiac remodeling has also happened. So we can wait for 3 to 4 months with these drugs, and many of the patients may not require it. So exactly that is the idea. So the CRTs, ICTs are not a replacement therapy for ARNI or other drugs, that are complementary, and that may be avoided if we use these drugs judiciously. Yes, we have evidence that around 55 to 58% of the patients of our heart failure patients in THFR or other Indian registries, they have diabetes, and diabetes always complicate the heart failure management. When we see in previous trials in the Western countries, the penetration of diabetes in heart failure was something like 30%, 20%, something like that. But in India, we see it around 58%, and that is why we need to have more and more emphasis on correct treatment in our patient population. And ARNI reduces CV death and heart failure hospitalization even more better in diabetic patients. And we have with ARNI, we also have seen that new use of anti-diabetic drugs and insulin initiation has gone down with the use of ARNIs. So this is really a very important fact one should be cognizant of. So HFpEF, we have a very robust trial called Paragon. Unfortunately, it missed the outcome significance, but it was only for the value of 6 patients, 6 primary endpoints. So it was nearly a positive trial. So we have, and especially those patients who are female and male less than 55 years, they showed benefit when ARNI was introduced in HFpEF patient. Before that, we had TopCat trial with MRAs, and we have some other trials now with SGLT2 inhibitors, which is really positive. But ARNI also in Paragon was probably I can say it is a positive trial even for those patients, younger patients, male patients less than 55 years, and female patient up to 61 years. It showed benefit. And then we have got Paramount trial results also showed improvement in several short domains with ARNI. So whenever the patients with HFpEF coming with 50-55 years of age, male patients or a female patient, I think there's no point not giving ARNI in these patients. You can definitely try it. We just discussed it. Between 40 to 57%, we have got some recommendations, and new FDA indication now opens up for use of cyclophosphamide in HFpEF patients. So with this FDA clearance, it really becomes more authentic, and it is obviously backed up with data. So contraindications is usually when we are giving, you should not be giving it direct in combination with ACE inhibitors, and you should be very careful about hyperkalemias which can happen, impaired renal function which can happen, and obviously hypertension which everyone knows of and familiar with. So ARNI, when it comes to renal safety, it is safer than ACE inhibitors. The hyperkalemia incidence, although we are very worried, it is lesser than the enalapril in the Paradigm heart failure trial. So we should be careful, but we should not be very scary. And then in hypotensive patients, again, we have to be careful. It is a real good question. So contraindication really in normal day-to-day situation is very less. I can say if we correctly treat these patients, then the chances of contraindication, if meeting contraindication in patients, will be less than 5%. And if you add SGLT2 inhibitors, it becomes even less because it counterbalances the problems with ARNI. So hyperkalemia with ARNI, you can start a low potassium diet to these patients, small doses of loop diuretics. Potassium binding agents can be given, but it should not be given for a prolonged period. Now we have a patiromer which is available, which can be given prolonged period also. But we can use SGLT2 inhibitors in these scenarios because they have shown to reduce chances of hyperkalemia with ARNIs. Yeah, this is a very real good concern. There are data that if the patient's ejection fraction improved, patient is stable. If ARNI withdraw ARNI, then chances of all-cause mortality in future becomes higher. So we should not stop the drug if the patient has improved. That is a real important point. So there is a subset called heart failure with improved ejection fraction, and that subset is all because of these drugs. It was not there earlier, all because of the new drugs and the cornerstone of therapy of heart failure, these 4 pillars. We have a subset of patients whose ejection fraction improves by more than 10%. Then we term it heart failure with improved ejection fraction. And please be mindful that we have evidence if you stop these drugs, again heart failure ejection fraction can drop down. So we should not discontinue, we have to continue our GDMT in these patients.